My name is Donna Klassen. I'm the co-founder and CEO of Let's Talk Menopause, a national nonprofit organization changing the conversation around menopause so women get the information they need and the healthcare they deserve. Our menopause talks are central to our education efforts. We have over 25 of them on our website, and you can go back and watch any of them. Before we get started, we have a few housekeeping items. These menopause talks are for informational purposes only and not as a substitute for medical advice or diagnosis or anything like that. We have disabled the chat, but you can ask any questions in the Slido app, which everyone should be seeing, and that's also where we're going to be doing our survey. The survey is really important to us. So please, if you can stay on and answer that, that would be great. And we also just want to thank Bayer for sponsoring all of our menopause talks in 2025. So welcome, Dr. Robin Noble. Dr. Robin Noble is the Chief Medical Advisor for Let's Talk Menopause. She's an OBGYN, really a GYN only, in Maine. And she has her undergraduate degree from Yale and her fellowship and medical degree at Columbia. She's a certified menopause provider, and she's board certified in lifestyle medicine. And she also recently completed her master's in healthcare delivery from Dartmouth. Not too shabby, Robin. And she's also just a wonderful resource for all of us at Let's Talk Menopause. So, Robin,
it's a pleasure to be here. Just happy to answer all these questions because I know, one thing we're really struggling with in our healthcare system in the US is access. So if this is a way where I can get more information out to more people, it's just, really rewarding for me. So thanks for coming and joining us. Your questions will likely be helpful for other people too.
Yep, definitely. So we're going to answer a bunch of questions today, and I'm going to just sort of frame it for everybody. We're going to first talk about finding a knowledgeable provider because we know that that's so important and people are struggling with that. Then we're going to talk about sort of where to get started, right? And what do I do? And sort of more essential treatment options. What are the screenings? What do I need to ask? What's important? And then we're going to get more into a deep dive on treatment options and sort of answer those questions. So again, we may answer some questions throughout, but we will also leave some time at the end for questions. So let's just get started with finding a knowledgeable provider. How does one go about doing that?
Yeah. It's so challenging right now because I think people have different constraints. One thing is their individual insurance might have, particular providers that are approved. I think getting into a primary care provider has been challenging for people, but it's important to say that's probably the most essential is having a primary care doctor, whether that's a family nurse practitioner or a nurse midwife, but somebody that is your primary care provider. Those doctors or providers can very often serve as not only a consultant for menopause and aging and midlife and wellness, but sometimes they're just not equipped. And we've talked about this a lot in the past. And I think sometimes that simple question of, do you feel comfortable managing my menopausal transition is a really nice opener because most people will admit if they really haven't had the training and it's not their area of expertise. And you might also uncover people that are really quite adept and say, yes, I do feel comfortable. That's a good opener, Donna. Don't you think that's a nice place to start?
I do. And sometimes, even though you've loved your OB, maybe that person is just, they don't have the time, right? And I think now more and more people are focusing on menopause. So I think there is an opportunity now to find people that are just doing GYN and more specifically menopause care.
Unfortunately, I think last count was something like 2,600 in the US are certified menopause providers. So that's a really small number to serve all of the US. But it's important to speak to the fact that your person doesn't have to necessarily be a gynecologist or even an OBGYN. They could be, a general practitioner, a family practitioner, but you're going to have to find that out. And I think one other really important part is that expecting to address all of this in a routine preventative care isn't realistic. So this type of kind of management, questions, diagnostics for menopausal healthcare is not something we can really cram into just a routine screening appointment. And that setting those expectations is really important so that you will not feel that you've been rushed or put down or not, partnered with. So I think recognizing that we probably do need an individual appointment, and in my druthers, my goal would be that everybody got coverage for an evaluation around the time of the menopausal transition. So they got the education and the background information that would really empower them to transition through this period in the healthiest way and in an individualized way. But we know that's not always happening.
Mhm. So basically, you're saying find a primary care provider, find a GYN, and they're going to be sort of your team, and that it's important to know that they do have some training and you feel comfortable with them, but also know that you can't just do things in one visit, that this is sort of over time, right? So we know that perimenopause can start 4 to 10 years prior. So like, when do people start? Like, at what age?
I mean, really, it should be what we call anticipatory guidance, almost like in pediatrics. We should know ahead of time some of these things that can happen. So, really, late 30s, early 40s, as a part of kind of reproductive management, healthcare for women, and, all of these things are important throughout that trajectory, understanding just the way we need to understand healthy eating, healthy behaviors impact our risk for high blood pressure and diabetes later on in life. We should know ahead of time that these things are going to happen. And just to add that I don't know that everybody even needs a gynecologist per se. If they have a fabulous primary care provider, that provider can do breast screening and cervical cancer screening and blood pressure screening. And some of them are quite adept at even managing the menopausal transition. So I would say it's really knowing your providers, knowing their scope of care and their comfort level and some of these things, but there isn't a one size fits all approach in terms of your healthcare team. And there's not a one size fits all approach in terms of menopausal management, because it's really a very individualized experience. Some people might really need to lean on behavioral health providers if they're noticing more exacerbations of anxiety and depression. Other people might really be interested in pursuing weight loss. And we now have people that are specialty trained in kind of obesity medicine. So I think it's really navigating where your needs are, which is, it's definitely harder. It's not a cookbook approach, but finding those team members that can support your choices and how we can impact those lifestyle modifications that are truly the most important thing for our wellness and our long-term health care.
Great. I'm going to ask you another question, and then I'm actually going to disappear for 1 second because I'm realizing that my laptop will die if I don't actually get another charge in. But I'm going to ask you, that leads to screenings. What are the most, like, what would you say are the screenings that women should be doing in their 40s, early 50s? Like, what should they be? What screenings?
We can take that while you get a little charged up. Okay. So it's always important to, make sure we're up to date on cervical cancer screening, which, typically over 30 is every 5 years with co-testing with cervical pap smears, including HPV testing. So that's generally every 5 if someone doesn't have a significant past history of cervical dysplasia or abnormal cells. We should be doing some breast cancer screening. And that incorporates, typically mammogram screening every 1 to 2 years in the 40s, or yearly even thereafter up until 70 or 75. But this is an area that's really been, highlighted. It highlights shared decision making, because one person's screening is not necessarily what everybody else might want to do. So we've got these broad recommendations of mammography screening starting in the 40s. We've also got colonoscopy screening for average risk individuals starting at 45. And the best colon cancer screening is really the colon cancer screening that we are willing to do, whether that's stool testing, colonoscopy, sigmoidoscopy, and they have varying intervals. And it's definitely informed by what our individual risk factors are, and then also what the findings are on the screening. So for example, if somebody has polyps found on a colonoscopy screening, their next screening is going to be a shorter interval. So we've got colonoscopy screening, cervical cancer screening, breast cancer screening. We've got blood pressure screening, lipid or cardiovascular health screening, as well as diabetes. And then we should all, particularly people at higher risk, be aware of skin cancer screening. And certainly dental visits are a really important part of preventative health care as well. our gum health really has an impact on our cardiovascular health. And then also, as I spoke before, depression and anxiety screening. We're seeing really an anxiety and depression in epidemic proportions in populations, particularly in midlife women. So understanding how much that impacts our overall health, I think those are the essential ones.
You know what? What about bone density?
So
Talk.
bone density isn't routinely recommended until someone's 65, unless they have risk factors. And those risk factors are typically under about 127 pounds, over 5'7", a history of steroid use, and a family history of osteoporosis or hip fracture. So there are some increased risk factors that would indicate screening could be helpful, as well as actually an early menopause, somebody who has long periods of amenorrhea in their early years, or say an early menopause or other risk factors. But in general, it's not routinely recommended or often covered by insurance until we're 65. But I do find it can be a really helpful thing to consider if someone's considering treatment options in menopause, because it can inform our decision making. So even if you're not considered at high risk, if you feel that a bone density is something that might make you either more compliant with calcium intake in your diet, more compliant with vitamin D supplementation if you live about north of Connecticut, or if it's something that might really impact your decision to consider using hormone therapy, it can be useful. And it's not a terribly expensive test. It's typically $150, $200 that goes to someone's deductible, but it's not routinely covered.
Right. And I think that's problematic because, don't we lose a lot of our bone density in the first 2 years post-menopause?
We lose about 10% of our vertebral bone mass in the 5 years surrounding menopause. But, that speaks to, kind of evidence-based medicine and what we decide is indicated at a population-based level, right? And then what is individually important to you. And I think that's a tension in kind of US healthcare. We're kind of stuck between what's a covered benefit, what's routinely recommended for the general population, and what might be uniquely important or informative for you.
Got it. So somebody asked a question here. How often should we have a routine exam with our gynecologist, and how frequently do we need a pap smear?
Okay. While you were charging, we talked about pap smear screening. Typically over 30 every 5 years, with co-testing, HPV testing for low risk individuals, average risk individuals, every 3 years if someone's had a history of treatments for abnormal pap smears. That's typically pap smear screening. Getting back to something mentioned earlier, we don't absolutely need to have a gynecologist in our repertoire. If your primary care provider is doing your breast health screening, your cervical cancer screening, your pap smear, as we said, but many people will like having both because they feel, and that's what I generally advocate. If your insurance covers a preventative visit with an OBGYN provider as well as your PCP, I think we all need the opportunity to pursue preventative care, lifestyle modification. And even if that provider happens to mention something about depression or diet or mental health or safety or seatbelts or texting and driving. So I double down on preventative care, but I understand not everybody might need or want that. Some people are so busy, they want to, one visit, get everything done, and that should be their primary care provider. So I don't think we absolutely have to have an OBGYN as well. But I'm definitely in favor if someone's willing.
So this question is for women who can't find a local menopause trained provider. How do you distinguish between all the online services? And I guess I just want to say that I think we mentioned, and I think that we're going to put in the chat how to find a provider online through the Menopause Society that has trained and certified providers. But I also would say that the online provider should also be trained in menopause. But that's a very good question. And I don't know if we can answer them. I think it's probably a little bit of like give and take, right? And there's some online providers that take insurance, there's some online providers that don't. Anything about that, Robin?
I mean, I am seeing that most of the online providers marketed as menopausal access are going to be certified menopausal providers, but I think it, through the Menopause Society, but I do think it underscores the fact that just because someone's certified in something doesn't necessarily mean they're going to be a good fit for you. I think the reality is that with those 2,600 certified providers in the States, many people are going to live in communities, especially in rural areas that don't have a certified provider. And I think some of these options are going to be a really good reality for some people, at least as a start, to do a consultation, especially if it's covered by insurance. But I think that has to depend on, the person, what they're interested in, whether their primary care provider can help them, whether they can use some of our resources to help kind of advocate even with their primary care provider, because I think we all have to destigmatize menopause. I think we all have to talk about it more. I think we all have to demand of our primary care doctors and all of our doctors in general, even if that's our cardiologists or ophthalmologists or dermatologists, that menopause is a thing that 50% of the population transitions through. And we have to demand that they have a better understanding and more options for us. So I think it can be a combination. And sadly, I think a lot of people are left to their own devices, which really contributes to inequity in this country and healthcare access. But that's what our mission really is, to try to help everybody from all corners get some good information and know how to self-advocate.
Yep, absolutely. So preparing for your appointment, what should you think about? Like, should you bring a symptom tracker? Like, we have an online symptom tracker. What would help you? Like, if people came prepared, how should they go in to talk to you?
Again, I think it's an individual thing. I think that specific appointment for your concerns is really necessary, because trying to squeeze that into preventative routine visit is really challenging. And we've got another talk on that. But as much as some physicians are taken aback with lists are really helpful, because all of us can be sitting in front of a stressful situation and forget our most important needs or questions or desires. So I think jotting down a list, I think whether you use our symptom tracker or you just kind of take stock in your symptoms, what's important to me as a physician are that person's biggest concerns and their goals. And they're I encourage people to really think philosophically about what they're maybe open to, what they're willing to consider, and really being open to new information, because I often see that people will come in with a particular idea about, for example, an IUD, an intrauterine device. And if they're open to more information and hearing about it, that could be something that's really helpful in managing their bleeding symptoms. So typically the way I approach it is I generally have a lot of ideas that could help in a particular situation, but I need to partner with that person. What's best for them? What are their goals? What are their most bothersome symptoms? Is it sleep? Is it weight? Is it mood? Is it, libido? So these things, not in necessarily a ranked order, but kind of the things you're most looking to, move the needle on is a really good place to start, if that's helpful.
Very helpful. Let's also talk, we're going to get into hormone therapy and finding a provider that's open to that. And we know that there are some providers that just aren't up to speed because we've had 20 years of very little education in that area. But one of the things that I always have a question about is there's perimenopause, right? And you're still bleeding, you're still getting your period, and how to manage that versus making that transition to menopause hormone therapy. Because menopause hormone therapy is different, right? It's not replacing. That's why we don't call it replacement therapy anymore. It's sort of giving you a bump up, right? So that some of your symptoms are more manageable and can help with some of the preventative long-term symptoms. But talk to us about that perimenopause and how to sort of, because we know estrogen goes up and down, up and down, up and down. Hormones are going down. What do you do?
And, I think there's so much confusion in this area. And I think that, the more we speak to this question, the more we help kind of explain what's going on. And even that term perimenopause, we say it's these years surrounding the menopausal transition, but it's often still so confusing for people. I find explaining what's happening is generally the best way to explain to my patients what's happening, because our hormones are kind of going up and down at ovulation and then up and down right before our cycle. We can experience a whole host of symptoms that many people just remember as like kind of PMS symptoms, but it's basically worsening of that. And why I find this perimenopausal distinction so tricky is some people have really bad symptoms in their 20s and some in their 30s, and they kind of escalate. So some people in their 40s are experiencing really bad perimenopausal symptoms, but their friend or their colleague might have had really bad symptoms their whole life. So to kind of say perimenopause and help, it's really kind of a continuum of how our cycles change. So you're absolutely right. It's a roller coaster. It's the years surrounding that transition because those peaks and troughs get bigger. So people start to often develop things like breast tenderness, bloating, mood symptoms that are exacerbated. The same things going on that happen in their 20s and 30s if they were ovulating on their own, but they're just heightened, right? And so one person might be really bothered when they're 38. Another person might be blissfully unaware until they're 52. And that's what's so tricky for people. But it's how we weather those ups and downs, how precipitous those ups and downs become, and then how we approach that, whether we want to treat kind of the sequelae, meaning like the downstream impacts on, say, our sleep and our mood, or whether we want to impact that hormonal roller coaster. And then you're absolutely right. Once we're not ovulating in menopause, those hormone levels are really, really low. That's
Right.
why, it's kind of flatlined. That's why testing at that rate, 5 years, 10 years into menopause, has no bearing whatsoever. We know where someone's hormones would be. They're kind of in the floor in menopause, but they're on that, Coney Island roller coaster in our perimenopause. So it's two very different treatment, scenarios in terms of how to help that person. And
Can
it's
you can
very
you just go back to that one more time? I'm a little confused, and maybe
okay.
our audience is too. So if there's these two, you're saying, explain that one more time, just sort of like these two in perimenopause, there's two ways to go about it.
So in perimenopause, some people might not have bothersome symptoms at all. Some
Okay.
people might have horrible symptoms that run the gamut from mood symptoms, anxiety, sleep, physical symptoms, dry eye, breast tenderness, bloating, menstrual migraines. But somebody else might have no symptoms whatsoever. Does
You're
that?
saying that with those people, you would do, like, if they don't have any symptoms, then there really doesn't need to be any treatment unless they want it. And what would you do for people who have a lot of symptoms in perimenopause?
I would explain to them kind of the why, right? What's happening? Because I find that's really empowering for women to understand why are they feeling that all of a sudden throughout their month they're getting, hit with kind of one symptom after another. When I'll try to identify for people how bothersome it is, I'll sometimes say, how many good days a month do you have? And some people will not make it my way until they have like a week or 10 days that are good. And the rest of the time they're just struggling with this. And so again, I'll partner with them and say, is this something you'd rather let it kind of run its course on its own? Or do you want to step in? Do you feel like you need help for these individual things? Right. And it can be so confusing because sometimes they don't recognize, or their doctor doesn't recognize that maybe their new dry eye symptoms, or maybe their new skin manifestations, like their worsening eczema or rosacea, that can all be fueled by this hormonal roller coaster. Or they might be having palpitations and be sent to a cardiologist. And so understanding that these big hormone peaks and troughs are what's triggering, say, these menstrual migraines or these anxiety exacerbations. So I try to start with kind of the explanation, what's typically going on, and then partner with them if they feel that, maybe they need a mood medication, like what we call an SSRI or an SNRI. And we can get into more details probably in another talk. And I know we have some on our website, but they might say, like, this is my most bothersome thing. Like, I lash out at the people that I love. I don't feel like myself. It's like 10 days of my cycle. It's really scary for me. Like, for that person, that could be the right strategy. Someone else might be hemorrhaging and bleeding through tampons and pads and not be able to leave the house because of their bleeding, but not have any mood symptoms or any dry eye or palpitation. So for that person, kind of managing their bleeding symptom, they might be good to go. Another person might be crippled by menstrual migraines. Like at ovulation, I saw someone last week that had migraines literally every 2 weeks for years. And, people were throwing migraine medications at her, and, it was really impacting her quality of life, her work, her family life. And understanding why that's happening and where we can have a hormonal angle can be transforming for that person.
So do you normally in perimenopause prescribe birth control during that time to stabilize hormones?
I would
Or
very often. Again, it depends on the person. what they want. I truly feel there's not a one size fits all approach. If they understand what's going on, and also it's important to speak to people's risk factors. There are situations where combination birth control pills are not safe for somebody, say if they're a smoker with high blood pressure, if they have a family history of clot or stroke. So there are certain scenarios where even if that might be a good treatment option, it's just not a safe choice. So then we have to, kind of go down the line. We could do this, we could do this, we could do progesterone only pills, we could do, various things. Similarly for sleep, you can help them with their hormone level, or you can help them with kind of sleep hygiene, other strategies, even sometimes sleep medications. So it truly is individualizing what's going on.
We have a couple of questions that sort of fit into this, so I'm going to ask them. Somebody went to their GYN about perimenopause and she prescribed birth control, hadn't had period for 6 months. I came in struggling with anxiety, felt confused about the birth control pills.
I see this all the time. And even if that might be the right treatment strategy, I find that if people don't understand the why, it feels like they're not listened to, they haven't been heard, they might not get behind the treatment. They just don't comply and they don't come back, which is, it's heartbreaking to me, because I think, first of all, I think birth control pills shouldn't be called birth control pills. We use them for so many other reasons. And some people aren't sexually active or not with a male partner. And so when someone throws a pack of birth control pills at them, even though that might control a lot of their symptoms, they don't understand why, and they aren't going to necessarily follow through. However, if I explained, probably too quickly, what's going on, those birth control pills might really, really help that person. But it's
And I
not.
guess part of the problem, right, is that person that we just asked that question, they haven't had their period in 6 months. So they might be postmenopausal and they don't quite know it yet. Do you know what I mean? Like they might have, that might have been their last period, right?
That's an important thing to talk about too. Absolutely. Like, when do you transition from, say, a birth control pill to, say, hormone replacement therapy? And there are a couple distinctions. One is that we think if people are younger, in their 40s, and they are skipping cycles or spacing 6 months, that higher level of hormone that's in oral contraception, combination oral contraception, is actually better for our bone health and cardiovascular health. So it's actually probably the better choice, even if they had an early kind of menopause or kind of late perimenopause. That 6-month hiatus doesn't fulfill the qualifications for that definition of menopause, which is 12, but it's kind of semantics. It's really what's going on with that person. So I would choose those birth control pills if there was a chance of unwanted pregnancy, if they were younger and we wanted that slightly higher level. Okay.
Right, because people who are below that age, right, the average age is 51, somebody who might have their last period at 41, that actually would be hormone replacement, right? Because you want to have those hormones for protection until you're in the early 50s, right?
And that's a really important message to get out, that early menopause is really, or even early perimenopause where they're skipping a lot of cycles. We really think it's not healthy for our bone health, our joints, brain health. So it's actually important to treat.
Got it. So somebody else asked a question: how do you discuss birth control? How can you discuss how birth control pills can affect one's hormonal health and things to consider when going off and aging? But you explained that, things to consider when going off. Anything?
So I didn't explain that, I don't think. It's a question I get all the time. If I'm on birth control pills, people will say, how do I know when I'm menopausal? And I'll explain to them, we won't, because what the birth control pills do is they suppress ovulation. So they suppress ovulatory function. So what I tell them is we generally pick an arbitrary time that we think is when someone's likely to be through menopause. So typically like 52, 53. The Menopause Society thinks it's reasonable to even keep people on till 55. I feel like that's a little bit late, but if we're concerned about that chance of pregnancy, we definitely want to go longer than we think we need. And then when that person reaches that age, I partner with them. We tend not to do it during like a stressful holiday season, but we will typically take them off birth control pills, and either they can see how they feel, whether they don't want to necessarily pursue menopausal hormone therapy, or they can segue right onto a lower dose of hormone therapy. And that's essentially the same estrogen and progesterone, but at about a third the dose. So you just kind of drop them down, and hopefully if they want to do menopausal hormone therapy, it's enough where they don't have hot flashes or sleep issues or joint pain, but it's not what we call kind of supraphysiologic or such a high dose that it slightly increases our risk of blood pressure, clot, and stroke. So it's safer to transition to a lower dose once we're not competing with that ovulation or ovulatory function.
Got it.
It's
That
super
was so, oh my
complicated.
gosh, Robin, though, that was really helpful. I hope our audience also found that really helpful. That was really amazing. We're going to move into treatment options. And one of our questions actually, I'm going to ask that question. And because this gets to the hormone therapy. What are your thoughts on menopause doctor influences who say the guidelines are outdated?
I think, unfortunately, we're in a time that's really challenging because we've got a bunch of self-promoters who, are really selling something. And I think the awareness is really important. We need to encourage women to get, and, we need to encourage people to get the information that they need to help shepherd them through this transition. I do think all medical information is a little bit outdated, to be honest. I do think American medicine, really made a big mistake over the last 20 years, and there has been a reanalysis of the data. The recommendations through, say, the Menopause Society are still very conservative, but we're behind in research. So yes, everything is outdated, and it's always going to be outdated, right? But we have to try to provide the most responsible care that we can. And I find I have to, it's a little bit nuanced. That's where that shared decision making comes into play. That's where I have to talk to my patients and explain we have limitations in the research. We don't know what someone like you doing X, Y, or Z looks like after 20 years of that, but we can do the best we can in kind of extrapolating that care. So I think we have to be a little bit more flexible. So I agree that we need to push these boundaries a little more. I think, we have not been served well by the healthcare system in terms of cardiovascular research, orthopedic research. I think these new terms like musculoskeletal syndrome of menopause, I see that day in and day out. Whether we have a label for it, it is real for some people. They can have joint manifestations and inflammation. So just because we don't have a study saying that menopausal hormone therapy impacts arthritis that's definitive, on kind of an individual level, it can be really important for people. I think we need to walk that tightrope, that line, thread.
Yeah. Yeah, thread that needle. It is nuanced, and there is more. I know at the menopause conference last year, there was a lot of talk about precision medicine. And I will just add, and maybe we can put a link to this for breast cancer, as somebody who has breast cancer myself. There's a study that everyone can be part of who does not have breast cancer from the age of 30 to 60. It's called the Wisdom Study. So you just Google wisdom and breast cancer, and through your own doctor, you can get more testing to decide like what breast cancer screenings you have.
We should put up on the links, because this is what I tell my patients, to do a breast cancer risk calculator, because I think that's really where we're moving to. There's the Tyrer-Cuzick score and there's the Gale model that actually you can fill in all your personal history, your age when you first got your period, whether you had pregnancies, what ages, a very extensive family history, and it will come up with a lifetime risk score. And if someone's lifetime risk of developing breast cancer is above about 20 to 25%, this is something we can all do ourselves, then that person should have additional screening, above and beyond just that mammogram. And that's where women need to be empowered. You don't need your physician to do this. You can find out. And then if you are at higher risk for breast cancer, this is where additional screening is useful. What's not useful is everybody hearing that mammograms aren't great and like maybe you should consider doing something, because it's really confusing to people. It's not indicated for people at low risk, and it adds a lot of healthcare costs and interventions when it's not necessarily needed. So I think we need to hone in our individual risk scores for things like breast cancer, for things like colon cancer, for things like osteoporosis. That's going to empower us to do the things that make a difference in our health.
Mm-hmm. So I'm going to go back a little bit to mammograms, because I think one of the things that I've been thinking about a lot is, not having fear-based medicine with the treatment options for menopause hormone therapy. But one of our people that work with us actually asked a great question: how do you mentally and physically prepare for things like mammograms and colonoscopies when they hurt, they're not pleasant? What are your thoughts on that? Anything to Any words, wisdom?
Anna, I think you might be better at that than me. Tell me
So
about your expertise. You're the
I do think that it's really hard when you have an association of pain with something. I think it's important to talk to the person ahead of time and let them know that you have some pain with it, but also to really practice some breathing techniques and to really know that like it's going to be over, right? Like this is not forever. This is going to be over. And if people have a fear of the results, which I know I put off some mammograms there in my earlier years because like, okay, well, look, don't ask, don't tell, kind of like if I don't, but that's actually really like really the worst thing you could do, right? So to really go in there and to sort of face your fears, right? Because it's sort of like we move towards the things that make us anxious. And so
you're talking about testing, and even many people have that experience seeing a provider. And we need to do a better job. We absolutely do. There's no excuse for that. I mean, I try to tell people, especially with that first mammogram, that, it's uncomfortable. It's like, putting our breast between two metal plates. And I do tell them oftentimes we see false positives, don't go to that dark place. Know that I'm going to be watching the results. If we need additional screening or additional diagnostic testing for, like, say, an abnormal appearance, because it's, there are limited views. They're not perfect, but it's the best thing that we have. So I try with that, but we also know that anxiety and fear actually increases the pain that we perceive. So, the more we can help people prepare for these, understand what they are, and everybody's got their things. I personally find the dentist really challenging, and everybody's got their things. It could be pap smears, it could be the colonoscopy prep that keeps them from doing a colonoscopy. That's where some of these stool tests, like whatever testing they're willing to do, is what's really important, and work with them.
And one of our mental health, we're going to be doing a little bit more of this, is sort of like challenging these like unhelpful thinking skills, like the thinking styles, right? The catastrophizing, or not looking at all the evidence, or discounting the positive of the things that you do, right? So I think that's also really important. Okay, we're going to get to some more questions because I think that the questions are helpful in terms of us going through everything we want to. This is about testing, and I think we answered this, but as someone who's hasn't been menstruating for well over a decade, it's hard to detect when I'm actually in menopause. Is there a test to detect this?
So I'm imagining that person, kind of three common scenarios, could have either had a hysterectomy, an endometrial ablation, or maybe have like one of these IUDs where they don't see their period. For some people, when I see them, I mentioned that they can be aware of cyclic symptoms. So even if someone doesn't have bleeding, sometimes they know when they're cycling, they have a little breast tenderness or PMS symptoms, or they have a little change in their discharge, or they have a little pelvic cramping. So sometimes people, even though they're not bleeding, know that they're still cycling. And then sometimes that stops or that spaces out, or instead they start to get more hot flashes, sleep issues. So very often we can still be cued into what's happening in terms of our ovulation and cycling and hormonal status. Other times people are blissfully unaware, and that is when hormone testing with an FSH and estradiol can be a really good snapshot. But it's only a snapshot at one point in time. And it can be very misleading for people because people at much younger ages can have kind of a one-time elevated FSH and someone can tell them they're menopausal, which is simply absolutely not true. Or on the flip side, someone can be experiencing really troublesome perimenopausal and menopausal symptoms. They can get a snapshot with a normal FSH and estradiol, and they can feel really gaslit because someone says, no, you're not menopausal at all. Your hormones look perfectly normal.
And that's because of that, those fluctuate, that the Coney Island roller coaster, right? Like that's why it's a point in time.
Right. But if we're truly confused, like I'm thinking of somebody that I know who was like blissfully unaware. She was like 54 with an IUD and wondered, like, could I be menopausal? And I'm like, gosh, I don't know. That's a situation where, by age alone, no bleeding, no clue, no symptoms. And sure enough, her FSH was sky high, her estradiol was really low, but she had no idea. And that person was actually at high risk for osteoporosis. So it's actually really important that we identify that so that she had that opportunity to do menopausal hormone therapy if she chose to do that for the prevention of osteoporosis.
How old was she again?
54, blissfully unaware, no symptoms.
How was how is she at risk for osteoporosis? Because
Tall and thin and family history.
let's see. Okay, got it. Got it. And that's why this individualized care, right? So that's why it's so important to know your family history. Okay, so another question relates to about hormone birth control. Does birth control IUDs impact onset of menopause and or make it harder to detect if there's already no period?
It makes it a little confusing, as I mentioned, because if they don't have that bleeding cue, they sometimes aren't as clued into what their cycle's doing, but it doesn't change that time, from everything that we understand. It has no impact on how long those ovaries are going to ovulate for.
Yep. Okay. Great. Another question. Do the providers listed as certified menopause providers also include functional medicine providers as well?
Yeah, you can become a certified menopause provider, I think, in any specialty. So it's an additional certification. I want to go back to that IUD though for just 1 minute, because oftentimes people don't understand, how helpful IUDs can be. The levonorgestrone or progesterone containing IUDs actually decrease the risk of endometrial cancer and avoid a lot of abnormal bleeding issues and heavy bleeding issues. It's probably one of the best innovations in gynecology in like 2 decades. And there can be a lot of fear. And actually, when you speak to that pain with placement, we're aware of that. We need to do better, but they can be really helpful in avoiding problems in the perimenopause, controlling bleeding, and decreasing that risk of endometrial cancer, because that's on the rise in the US.
Great. Okay. Another question. This is a good question. Went to a sexual health doc first time with a mirror and the doc explaining my lady parts. Finding most women haven't had this. Is that something you do in your practice? And what are your thoughts?
I sadly don't do it routinely, and we should do it more. Again, I think it speaks to all those things we're trying to do. I think the more awareness and destigmatization we pursue. I think Jen Gunter's book, Menopause Manifesto and Vagina Bible are great. People who are, there was a New York Times article on the clitoris. I mean, I think this awareness, I think for a younger generation is demanding it. I think sexual health and empowerment, yeah, all for it. Admit that I don't routinely do it because I think some of this is a time crunch.
Yeah, right. You're a gynecologist and you see, I mean, I know how thorough you are, and think about all the things that we just talked about, right? And how do you fit that into a couple of visits, right?
That's why I end up feeling inadequate, even
Right.
with what I try to do, because I can't possibly identify everything. And
Yep.
yeah,
I think also this should start earlier for teens and people in their 20s. Like this is something that we should be doing more of. I will also say though that a lot of our doctors that are more the urogynecologists probably do this. The Dr. Rachel Rubin, the Dr. Kelly Casperson, right? Like, but that is something that I think we should start doing, not just when we're 40, 50, when we're teenagers, right?
I might take issue with that because I don't think urologists are doing it more than we are.
You don't think so?
Those two for sure. But the female urologists are probably, in general, across the country, not a better place. Those two in particular, like anybody focused on women's sexual health, has, additional expertise.
So maybe a women's sexual, yeah. Okay, that makes a lot of sense. Okay, so what about if you had a uterine ablation and your period stopped? Would determining whether where you are part of a well visit? Would determining where you are to be considered a part of a well visit?
Yeah, again, and I think sometimes, that's similar to the ablation, the IUD, or the hysterectomy scenario where we don't know. We don't have that one piece of the equation. So very often they're aware that they're cycling, and then no lab testing is going to be helpful. If they're questioning it, if they're having some new symptoms, even if those are palpitations, skin manifestations, dry eyes, or periodically, because they're in this kind of more confusing setting, doing a test that's that snapshot could be useful, but I wouldn't say it's routinely recommended.
Okay. So I'm going to ask you a question now and kind of step back about this menopause hormone therapy, and then we're going to get into some lifestyle and other treatment options, including other medicines too. How do you prepare to talk to your doctor about hormone therapy? Like what questions should they be asking?
I mean, I find it most helpful if someone says, I have questions about hormone therapy. Questions if it could be right for me, if it could be something I might want to do, want to learn more about it. I've developed kind of a little handout for my patients that I constantly need to update, and it's a little outdated already. Speaking of that outdated medical information, we're constantly pushing these boundaries. But I think just being open to, is this something that might be something I want to do? Is this something I could learn more about? When would I maybe want to pursue this? Why would I maybe want to pursue this? And what are the implications for kind of longer term risks? I find recently what's maybe most helpful with my patients is kind of thinking of like 4 broad areas when they start thinking about whether hormone therapy is, an option for them, a choice they want to make. And I have them think about their cardiovascular health, their breast cancer risk. That's where that breast cancer risk calculator comes into play. Their bone health and what their risks are, because we know it really protects bone health. And then, unfortunately, it's a very gray area, but dementia. Dementia is something that women are more and more, and people, everybody in general, are more and more aware of our dementia risk. And unfortunately, the research that we have right now is really gray. What we seem to know right now, and I think doctors need to be definitely more humble. We don't know it all, but estrogen alone, hormone therapy for those who have undergone hysterectomy is protective for cognitive function. Okay, and estrogen alone, hormone therapy, does not increase the risk of breast cancer. In fact, there was a slight decreased risk in breast cancer, perhaps. Combination hormone therapy, typically when people have a uterus, we need to do estrogen and progesterone. There are some fancy tissue selective options that don't require a progesterone. And then there's kind of a more local option with that levonorgestrel IUD that's a little bit more like estrogen alone, but in kind of a broad, category. Combination hormone therapy seems to increase our risk of breast cancer very slightly after about 4 to 5 years. It's like, additional 1 in 1,000 women. So it's very small, but that means different things to different people. Some people are so acutely concerned about that for them, that could be a deal breaker, right? But that selective estrogen receptor modulator, that fancy estrogen, I kind of call it, could be something they're interested in. But the combination therapy,
that does not go because that does not go to the breast tissue. Is that right?
and it's not a progesterone. So it's the addition of the progesterone that seems to slightly increase the risk of breast cancer and dementia. The dementia data is really tricky. There was a Danish study that showed that it was observational, so we don't know, it wasn't a controlled study. But I tell my patients it's unclear, but it's certainly possible that estrogen plus progesterone in kind of broad strokes could potentially increase our risk of dementia. Now, what's super tricky about this area is we also know sleep and hot flashes are also markers for dementia. So I have a number of patients.
And also hot flashes for a marker for cardiovascular disease, right?
So they're like, well, it's catch 22, right? But I want to be honest with people. I'm not out there selling anything. I need them to be informed. And I have some patients that continue on hormone therapy for decades into their 80s and 90s.
Yep.
They need to say to me pretty much every year is they understand this could potentially increase the risk of breast cancer, even if it's small. And they need to understand that it could potentially increase their risk of dementia. But we know it's protective for bone health. And for those people, it's a quality of life issue. It's a philosophy issue, so I individualize care. But I hope that helps. Like those categories of dementia, breast, bone, and cardiovascular. And then certainly
GSM. GSM as well as a long-term.
Well, GSM actually, we treat better with local vaginal estrogens, and that's not even controversial.
Right.
So
that's not controversial at all, everyone.
we should say GSM for our listeners. Genitourinary syndrome of menopause. Think of local vaginal dryness, discomfort, urinary symptoms, pain with sex, sometimes even an impact on prolapse, and certainly urinary tract infections. There's evidence that local vaginal cream that is extraordinarily safe. Even we've got data now for a lot of breast cancer survivors. There's no timing hypothesis. People can start when they're 60, 70, or 80. We have all those benefits. But those symptoms are actually better managed with a local cream, and that can be continued indefinitely.
I'm going to go through, we have 10 minutes left. We're going to go through a bunch of questions really fast. Okay. What options are there if someone has a history of DVT, PE, quality of life is affected, and after removal of HRT?
There is some emerging data that transdermal estradiol through a patch in low doses with shared decision making can still potentially be used. Okay, we've got the, newer medications, fezolinetant, that acts at kind of central receptors in the brain for hot flashes, that can be used. We've got a whole position statement that we can put in the chat from the Menopause Society on non-hormonal options, cognitive behavioral therapy, some SSRIs. So there are lots of treatment options if we have to be non-hormonal. But I'd also point out that there are places, even in these very tricky clinical scenarios, where with shared decision-making, we sometimes do transdermal estradiol as well.
Yeah. Okay, from Richard, what are the options for women in medical menopause before age 45 for hormonal breast cancer to protect bone brain health?
It would be those ones that I mentioned, again, fezolinetant and this new class of medications that affect kind of the KNDy receptor in the brain, the thermoregulatory center, some of the, SSRIs, SNRIs, cognitive behavioral health options. And then also, I think, certainly we can use some of these vaginal estrogens. And there's also emerging data, out of Europe that these fancy estrogens or tissue selective estrogen complexes can potentially be used, and they don't stimulate the breast or the uterus. I find that our US oncologists are very, very nervous about them. And again, we need to push those barriers. But for an informed patient, there's evidence for safety for not only that selective estrogen receptor modulator, but also Osphena, which is an oral medication that targets the vagina that doesn't stimulate the breast. So there are some options. I mean, really, I want to underscore the fact that there are probably options for almost every clinical scenario out there. So you need to get you help if you're having bothersome symptoms.
That's right. Yeah, you don't need to suffer. And also for bone, I think that's where like let's talk about supplements and vitamins. What do you recommend 40s, 50s?
Okay, so I don't recommend a lot. I'm a real food person. I'd rather you eat real food, healthy food, plant forward, more fiber in the US. We don't eat enough fiber, less animal fats and saturated fats, more plant proteins and plant fats. However, we need to get adequate calcium in our diet. So if someone is not getting adequate dietary calcium, they absolutely need that. And then if they live in these northern climates, we need vitamin D. Vitamin D and calcium are really important to support bone metabolism, and our bones are constantly breaking down and reforming. So we need D and calcium. If someone's a vegan, they need a B complex. There hasn't been great data one way or the other on a multivitamin. So I say you be you, and if you want to get your D that way, do a multi. If you want to do just D, and you might not even need D if you're like a New Yorker like Donna.
You don't need a D in New York?
No. Not from a population-based study. And, that brings up a question about testing. We also don't typically need to do vitamin D testing. But if you look at me that way and you go, wait, I don't need D, maybe we should check your D, right? But by population standards, most people kind of south of Connecticut get enough natural D.
Okay, great. We have like 4 more questions left. Any age limit for women to have an IUD?
Not that I'm aware of. I mean, your insurance probably won't cover it, and it's definitely off-label. It's not FDA indicated for anything other than kind of contraception. But there's no age limit that I would find in my practice.
Okay, somebody has heavy bleeding over the age of 52. Doctor said she did not see anything and it's normal. Should I seek a second opinion? It's been going on for over a year.
I think there are loads of treatment options I could come up with. So it depends how bothersome it is for you. I explain to my patients, the first thing is making sure nothing's wrong. The second thing is deciding what's right for you. So I think it's great that she got information that nothing was concerning. But I think if this is bothering someone, impacting their quality of life, sometimes people become anemic. Sometimes, it impacts their work and all sorts of things. Plus, it's not even green if we need to go through all sorts of kind of panty liners and stuff. So I think lots of treatment available, but great that nothing's wrong.
Yep. Somebody asked about testosterone, and I don't know if we have enough time to do testosterone. We probably don't. We want to just say something really briefly about that. We have other menopause talks where we talk about testosterone too. So maybe we'll have one menopause talk just on testosterone. But
yeah, and I can give you kind of, my feeling. I think this is one of those areas where medicine's kind of changing. It's generally not thought to be indicated in perimenopause. In menopausal women, or people, with their ovaries and so forth, it's indicated for the treatment of kind of bothersome decreased libido, which I think is really narrow. So I think it's an area where people are really curious about it. We know what happens with testosterone. It really takes a dive when we're about 35, and then it continues to kind of drop off over age in men and in women. It spikes a little bit around that late perimenopause because our estrogen drops. So we get kind of a little bit of a lift on that free testosterone. But if someone feels that it's really an area where they are lacking and they are curious, it's something that I think we can do judiciously. I think there are a lot of crazy things going on in the internet. I think there are a lot of people giving people pellets, which I certainly don't agree with, because you can't dose them effectively and they're, not regulated in the same way. But you can do judicious physiologic testosterone supplementation in people who are informed and feel like it's an issue. I don't feel like it's a first line therapy. I generally tell people that I think we should, if they want to do hormone therapy, do that first with estrogen plus minus progesterone if indicated. And then if they still feel it's kind of a hole for them and it's bothersome to them, yeah, I do it in a judicious way. And that's the one area where testing is indicated to make sure they're in that physiologic range. I see these crazy scenarios where people are in like 100, 150 when the normal range for women is just under 50. So we weren't at 100, 150 in our 20s, 30s, 40s. And I see people doing all of these, what I would say, for lack of a better word, wonky things, making a lot of money and preying on people.
Mhm.
That's my
We
thought.
did send Dr. Noble and another doctor, Dr. Flagg, put together our tips for finding the menopause care you need. And we talked about that, some of the red flags to look for. So we are going to end though and get the survey out there. I really want to thank you, Dr. Noble. It was really incredible. So informative, so wonderful. Thank you so much. And
I'm a fast talker, but you know how to get me, Donna. If you want to do another one, it's really our mission. So appreciate being here. I'll sign off. You guys can do the survey. Take care. All feedback is appreciated because we're constantly trying to improve and serve you the way we can. Bye.
Great. Thank you so much.